everyone. Thanks so much for joining us. My name's Jackie Rao, and I'm the program manager for the Michigan Collaborative for Type 2 Diabetes. I'm sure a lot of you have gotten a bunch of emails from me lately, so nice to see some of you, and hopefully it helps to put a name to a face since you'll continue to hear from me in the future. We have our co-director, Dr. Heidi Diaz, who's a pharmacist, and Dr. Jonathan Gabison, who is a primary care physician, who are going to be giving the training on medications this morning. I'm going to kick us off with just a little bit of procedural things and walk through some of the CME components and how we can make sure that your attendance gets tracked for the meeting, and then I'm going to hand it over to Heidi. So I'm going to go ahead and share my screen so that we can get this all sorted. So I'm going to share this CME information, and then this is also going to be shared with you afterwards as well via a, one second, via an email from our administrative assistant. So to receive credit for CME, you're going to text 76470 to the number on this screen, and it will give you a link to the evaluation. If you somehow miss texting this number, you are still able to access the evaluation and get credit for the CME. I think they're just trying to make it as easy as possible for you to get the correct link, but logging in at the link below will get you to the right spot to complete the evaluation. If it's your first time claiming CME from Beaumont, you'll likely have to make an account for it. We're offering continuing education credits for physicians via AMA Category 1 credit. We're offering nursing CE, pharmacy CE, and dietetics CPEU, and it's approved for 1 credit for this course. And then here's our disclosures for the presentation. Dr. Gavison is a consultant for Eli Lilly, and Dr. Ashman, who is our program director and the director for these trainings, has stock in the publicly traded companies listed here. And then the last piece, so as you know, attending these meetings is a requirement for the collaborative. We have a sign-in process that just makes it easier to link up people's Zoom names with the person that we have like in our back-end system. So we are going to send you a link after the meeting. I'm also going to put it in the chat right now. It's just to have you sign in. You'll type your name, your PO in practice will automate, and then if you can put your Zoom name exactly as it appears to you right now, that would be incredibly helpful for us just in tracking it and making it a little easier to link everybody up. So with that, I am going to stop and I'll put that link in the chat and we'll hand it over to Heidi.
Thanks, Jackie. So welcome, everybody. Thanks so much for joining us. I'm happy to get this new group of practices joining MCT2D. So here is, well, hopefully, there we go. Here are the topics we're going to be covering a lot in the next 50 or so minutes. So with that, I'm going to go ahead and turn it over to Dr. Gabison to kick us off.
Dr. Gabison, you're muted if you're talking. Okay. Did you click the button in the small left-hand corner where it says mute? I can also ask you to unmute and we can see if that works.
Thank you for the help. I can't see myself on the screen or my Zoom on the screen.
No worries, we can hear you now, so you should be all set.
Hi, everyone. I'm Jonathan Gavison. So I'm going to start with the introduction. And to start, I always like to think about what is MCT2D, right? That is an acronym that fills our mouth, and it's very difficult to say. The MCT2D is the Michigan Collaborative for Type 2 Diabetes. It's a statewide continuous quality initiative that focuses on improving Type 2 diabetes care throughout the state of Michigan. For those of you unfamiliar, I think it's important to understand how the structure works. So funding for MCT2D comes from Blue Cross Blue Shield. Organizational support comes from the University of Michigan, and we work to offer best practices, resources, and support to provide high-quality healthcare. We obtain data and receive feedback from you all to help improve the care throughout the state. MCT2D was created because there's a need for people with type 2 diabetes. Over 37 million people in the United States are living with diabetes today. More than 1 in 9 people in Michigan, more than 1 in 9 adults in Michigan. 239,000 Michiganders have diabetes but don't know it. And over 2.7 million people in Michigan have pre-diabetes but have not been diagnosed. And this is an equity issue. It is worse in Black Michiganders and Hispanic Michiganders, and twice as high in people with disabilities. MCT2D aims to do this with 3 quality efforts: improving the prescription of evidence-based medications, supporting a low carbohydrate diet, and expanding the use of CGMs. Today, we're going to focus on appropriate utilization of incretin hormones and SGLT2 inhibitor medications. I'm going to hand it off to Heidi.
All right. So hopefully you guys can see my screen now. So about 5 to 10 years ago, if I had a patient with uncontrolled diabetes, I would likely start insulin. And so taking a look at the pathway on the top, this leads to weight gain, perpetuating insulin resistance, increasing insulin requirements. And while we get our patients hopefully to their A1C goal, it's at the cost of accelerating diabetes complications with no cardiovascular benefit. So if we fast forward today, looking at that lower path, I'm much more likely to start an SGLT2 or a GLP-1. And this offers my patient an opportunity for weight loss, reduced endogenous insulin production, and also, most importantly, provides cardiovascular and renal risk reduction while getting them to goal. Let's see here. There we go. So last year, we saw a huge change in the ADA standards where metformin was actually removed from the top of the banner. And so now, after lifestyle considerations and management, we have to ask ourselves, what is the predominating goal for our patient? Is it cardio risk reduction, or is it glucose lowering and weight management? So if we have a patient that could focus that could use and benefit from cardio risk reduction, we then focus our attention on the left side of the ADA standards. And we then pick a first-line agent based on the predominating risk factor, whether it's ASCVD, heart failure, CKD, or having multiple risk factors for ASCVD. And this is independent of metformin. Certainly, if glucose lowering requires dual agents, then we can add metformin at that time. Switching to the right side, if patient does not require cardiorenal risk reduction, we then have options for agent selection based on the appropriate amount of glucose lowering they need, that middle column there, or focus on weight loss goals. And so those are mapped out on the far right column. Switching back over to you, Jonathan.
Okay, hopefully I can get this right this time. So we're going to start by taking over the next section where we're going to talk about these kinds of medications and review incretin mimetics and SGLT2 inhibitor drug classes. And to do this, I like to start with a case. So JL, the 47-year-old, history of metabolic-associated steatotic liver disease, formerly known as NAFLD, type 2 diabetes, his BMI is 50. He has obstructive sleep apnea, chronic knee and back pain. He's currently taking metformin and sitagliptin, which is a DPP-4 inhibitor. These are his labs, notably for elevated A1C, ALT, and AST is borderline. And he presented, he wanted to talk about weight loss. Just to give you some background, he lives a high-stress lifestyle. He's a lawyer. He has a tendency to emotionally stress eat. He binge eats. He uses alcohol as a coping mechanism. He has issues with portion control, and he always feels like he's hungry. And for sleep apnea, he's not using his CPAP. Weight loss is a very important target for treating diabetes. So if one loses 2 to 5% of their weight, it reduces their fasting blood sugar, their A1C, and improves their blood pressures. 5 to 10% of their weight improves metabolic function, and 10 to 15% weight loss can improve sleep apnea, arthritis, and 15% can or more can have a disease-modifying effect and lead to diabetes remission and improve mortality. So for JL, losing 5% of his weight is about 15 to 20 pounds. 10% of his weight is 35 to 40 pounds, and 15% of his weight is 55 to 60 pounds. When thinking about the anti-hyperglycemics, I like to think about them in general and how they affect weight. Medications that increase insulin, exogenous insulin and sulfonylureas, cause weight gain and also carry additional risks of causing hypoglycemic events. So the medications on the left have weight loss benefits and do not cause hypoglycemia. And the medications on the left also help combat hyperinsulinemia and lower blood sugars. How does insulin cause weight gain? Hyperinsulinemia is caused by elevated blood sugars over time, leading to subsequent insulin resistance. This causes increased fat storage and halts fat oxidation. This increases visceral adipose tissue and causes adipose hypertrophy, so those fat cells get really, really big. Increases inflammatory effects, also increases circulating fats, which cause a decreased response to insulin. This is a vicious cycle and leads to more and more insulin requirements. To help our patients and to achieve long-term health outcomes, we should try to limit this hyperinsulinemia insulin resistance circuit. To help JL combat his hyperinsulinemia and diabetes, we're going to discuss the incretin mimetics, the class of medications that are best equipped to do this. So incretin mimetics, so these are the GLPs or the dual agonists currently on the market, GLP-1, GIP, are potent anti-diabetes agents that can lower A1C 1 to 2%. As monotherapy agents, they do not cause hypoglycemia. And then depending on the medication you choose, they can have robust effects on weight. And we'll talk about the cardiovascular and renal effects as we go on. So again, incretin hormones are GLP-1, GIP, and glucagon. I like this graphic because it shows where some of the synergy does and does not occur between the GLP, which is going to be labeled in red, and GIP. GLP-1 works via 3 mechanisms. 1, it increases satiety. It signals in the brain to feel full, decreasing food noise. 2, it delays gastric emptying, making it harder to consume more food after eating. And then 3, it increases postprandial insulin and decreases glucagon when blood sugars are high, which lowers hepatic gluconeogenesis, making glucose in the liver and lowering our fasting glucose levels. GIP improves insulin sensitivity in certain cells in the body, while also improving insulin secretion postprandially, similar to the GLP-1. And both of these together, they make the body respond better to glucose after a meal. It increases glucagon when our blood sugars are low, but has less of an impact with sugar levels, with glucagon when sugar levels are high. And we're still unclear if and what impact GIPs have on the nervous system. There are 5 incretins that are currently on the market. These are their respective doses, effects on A1C, and details about how the medication is consumed. All are injectable except for the oral form of semaglutide. Injectable semaglutide, tirzepatide, and Trulicity have the most robust effects on A1C. The key points about oral semaglutide is that it is a daily medication as opposed to weekly. We go up on the dose every 30 days. It's important to counsel patients on how to take oral semaglutide. You take it 30 minutes before food or beverage or other medications and with no more than 4 ounces of water. If you do this less than 30 minutes, it will reduce its efficacy. And if you do it more than 30 minutes, it will increase its absorption. MCT2D has, the website has handy resources to help with dose escalation for incretins and SGLT2 inhibitors. Typically for incretins, we increase doses every month as tolerated to maximize their therapeutic benefit and potential weight loss. Many of you might be aware of the black box warning on all incretin medications for C-cell tumors. I ask every patient I prescribe a GLP-1 or dual agonist, whether they have a personal history of medullary thyroid cancer or a family history of MEN2 tumors. The incretin hormones are also contraindicated if they've had a previous hypersensitivity to another medication in the class, as well as if they're pregnant or breastfeeding. Incretins, they're large molecules, and they have a low risk of passing into breast milk, but there's very limited evidence during pregnancy and with breastfeeding on their use, and so we put them as a contraindication in these cases. For tirzepatide, it interacts with birth control pills, and so this delay is largest after the first dose and diminishes over time. For those patients that we start tirzepatide on who are using birth control, it's important to counsel them on using barrier method for 4 weeks after starting and for 4 weeks with each adjustment dose. There are some other precautions on the package labeling that I screened for prior to prescribing. So a recent meta-analysis showed no difference in the rate of new onset pancreatitis between incretins and placebo, with the rates being about 0.3 and 0.4% in each group. On a practical level, though, if I know why the patient had pancreatitis and we fixed it, like gallstones or hypertriglyceridemia, I would consider using an incretin hormone for that patient. I don't think it would be a indication to not use it. But for a patient with pancreatitis of an unknown cause or chronic pancreatitis, I might avoid this class of medications. All patients will have some GI side effects that we'll talk a little bit more in detail with later. I avoid GLPs or incretins in patients with gastroparesis and monitor patients with acid reflux more closely when starting GLP-1s or incretins, and give good anticipatory guidance and symptomatic treatment for GI side effects. Interestingly, AKI's acute kidney injury is listed as a precaution because of the GI side effects of these medications, the nausea, vomiting, or diarrhea, which can exacerbate dehydration and cause an AKI. So patients at high risk should have closer monitoring when you're starting and titrating these medications. The FDA label has warnings about transient short-term worsening of pre-existing diabetic retinopathy, which occurs when glucose drops sharply and can occur with incretins as well as insulin. So if a patient reports sudden change in their vision, especially when starting one of these medications, I would consult with their ophthalmologist. We know that incretins alone do not cause or increase risk of hypoglycemia, but typically results in lower need for other medications that cause hypoglycemia. But if they're on one of those medications, it's important to be paying attention to it and counsel our patients about the risk of hypoglycemia. And then finally, there was a retrospective study in 2023 that reported concerns for increasing risk of thyroid cancer and thyroid disorders for people with diabetes on incretin hormones. Overall, though, the benefits of the incretins, which we're going to get into, outweigh any small absolute risk of thyroid disorders, but it's important to share this with patients and monitor for signs of thyroid dysfunction. The biggest barrier for incretins typically are the fact that they're injectable, their cost, and the GI side effects. I honestly, when I first started practicing, I was adverse to prescribing it because I thought most people would be turned off by the fact that they're injectable. Then I learned and I showed patients the size of the needle, and it usually helps them overcome that concern. And then the fact that 3 of them, dulaglutide, semaglutide, and tirzepatide, are all weekly medications makes that a little bit easier. One of the most important parts about prescribing these medications is the anticipatory guidance and explaining common side effects to the patients. Approximately 20% of people will experience initial nausea, and this is typically mild or moderate and resolves over time. For most of my patients, it does not impair their ability to eat or continue taking the medication. I tell them to let me know if the symptoms do not resolve, and we can titrate their dosing more slowly or even go down to a lower dose until symptoms improve. Constipation is also a common side effect, affecting about 10% of patients. For them, I recommend increasing fiber and water and using Miralax as needed, and that's typically effective for most patients. For surgery, if someone is about to have a surgery, they should hold incretins for 1 week prior to prevent risk of aspirating during surgery. Okay, so that was a lot of contraindications, relative risk. Why are these medications good? So we heard a little bit about weight loss, right? So they can help our patients lose weight. Here are the 5 incretin medications, and on the bottom you can see the average weight loss percentage with the medication. So tirzepatide at 15%, semaglutide at 10%, liraglutide at 6%, and dulaglutide at 5%. Oral semaglutide has a less robust response, while exenatide's weight loss is negligible. On max dose of semaglutide, 68% of people with diabetes lost 5% of their weight, 52% lost at least 10% of their weight. On max dose of tirzepatide, 80% lost 5% of their weight, 57% lost 10%, and 36% lost 15% of their weight. What are the additional secondary benefits to these medications? Liraglutide, dulaglutide, and semaglutide all have evidence to reduce major adverse cardiovascular events. The others do not. Semaglutide has been shown to decrease progression of chronic kidney disease and albuminuria. This is in the FLOW trial that was recently published in May. Exenatide requires more caution in those with stage 3 CKD. So I generally switch to another incretin that provides more of a safety profile. Liraglutide was studied in stage 3 chronic kidney disease and found to be safe, with a notable decline in new onset proteinuria. And dulaglutide was studied in stage 4 kidney disease with a notable slower decline in renal function compared to glargine. Tirzepatide has not, the data from the cardiovascular outcome trials has not been published. It will be published in the spring of 2025. From an educator standpoint, the 3 on the left, the dulaglutide, exenatide, and tirzepatide, are all auto-injectors, while liraglutide and semaglutide require pen needle attachments. With liraglutide and semaglutide, the patients will see the needle. The pens are multi-dose pens, and pens need to be primed before use. The person should hold the button for 6 seconds after injecting the dose. That's a lot of information to explain to patients, right? We're not doing that in our clinical visits necessarily. MCT2D website has great videos on the website that explain how to use each of these incretin mimetics. So how do we pick what's best for our patient? The first thing that I think about is there a secondary benefit? Are they at high risk of cardiovascular disease? Cardiovascular outcomes, again, support liraglutide, semaglutide, and dulaglutide with tirzepatide data coming in the spring. For weight loss, tirzepatide is greater than semaglutide, it's greater than liraglutide, it's greater than dulaglutide. For CKD, the FLOW trial demonstrated a 24% lower risk of kidney disease-related events compared to placebo for semaglutide. Dulaglutide is safe for individuals with CKD, but there's no direct study showing reduction of kidney disease. So back to the case, how would you help JL manage his diabetes? At that initial visit, we started JL on semaglutide and stopped the sitagliptin. You can't use a DPP-4 inhibitor at the same time as incretin. We discussed the importance of sleep, and he started adhering to using a CPAP, and we discussed starting a lower carbohydrate diet. After 6 months, JL was down 15% of his body weight, and to date, he has maintained that weight loss. His A1C is borderline normal. Liver enzymes return to normal, and his cholesterol panel looks great.
Thanks, Jonathan. All right, get switched over here. So now we're going to switch over to our SGLT2 inhibitors. And so I would like to start off with a case. So this is patient PV, 64-year-old male with type 2 diabetes, current A1C of 8.6, who was recently admitted for an NSTEMI. Past medical history is significant for neuropathy, history of CABG, stage 3A CKD, and obesity. Currently taking glargine, metformin, and dulaglutide, and previous diabetes medications are listed here. So before we dive into the details, I always just like to give a summary. And so SGLT2s are not quite as potent as our GLP friends. And so we usually look for about 1% lowering in A1C. They are not associated with hypoglycemia. And weight loss across the various SGLT2 trials demonstrated about a 4 to 5 pound weight loss. We'll get into all the details regarding cardiovascular and renal benefits here in a few minutes. So SGLT2 is a protein that facilitates 90% of glucose reabsorption in the proximal tubule of the nephron. SGLT2 inhibitors block the glucose reabsorption, thereby lowering the threshold and increasing urinary excretion of glucose. I'm sure you're all very familiar with these doses here. These are all once daily medications, and because they act like diuretics, patients should, of course, be told to take them in the morning. I always kind of emphasize that because you'd be surprised if we don't. Patients take these at all sorts of different times of day. When it comes to dose titration, typically we wait about 4 weeks up to 12 weeks. And it's really important to consider tolerance prior to the need for glucose control. And so considering where the patient's blood pressure is, if they're experiencing any side effects, their volume status, and if all of that is stable and they need more glycemic control, then by all means increase to these max doses listed here. It is important to keep in mind the mechanism of action. So as their renal function decreases, the amount of glucose delivered to that proximal tubule also decreases. Thus, the glucosteric efficacy declines. And so this is why I have the last column outlined. And so these are the renal cutoffs if you're wanting glycemic impact from these drugs. I'm sure by now you've all heard of Brenzavvy. So this is a medication, an SGLT2, that was approved in January of 2023. It went through rigorous clinical trials. It was never really picked up by any large manufacturer, but a couple of pharmacies got together and we're able to get it released and is FDA approved. But this drug is only available at those 3 online pharmacies. So Cost Plus, you may have heard of, is Mark Cuban's pharmacy. So Brenzavvy is 20 milligrams, 1 dose, so there is no titration instructions, taken once daily. But the big thing is, at these online pharmacies, patients can get a month's supply for around $50. So given all the troubles and challenges we run into with patients affording their meds, this can be an option. However, I do caution in that this is only approved for glucose lowering. It was non-inferior in cardiovascular trials, thus it does not have any added benefits for ASCVD or renal risk reduction. And so you might want to consider using this in a patient who perhaps is on a GLP and they already are getting the CV protection, or in a patient who needs glycemic control and has a low risk of ASCVD. And just as a caveat, the reason there's a cat here, this was the first oral medication for cats approved in December of 2022. Contraindications are listed here for SGLT2s. And so here are the main side effects we're going to walk through. And it's really important that we're covering these with each patient that we prescribe this medication to. And so as I walk through, you're going to see mitigating strategies pop up to the right. So the incidence of yeast infections are more prominent than the risk of UTI. So about 10 to 15%, regardless of sex, can experience mycotic infections. And I've seen this clinically. It's important to really stress genital hygiene. And even in the summer months, I go as far as to recommend cotton underwear just to try to offer decrease their chances of these side effects. We may want to consider avoiding SGLT2s in patients with a past history of frequent candidiasis or balanitis. While those that have had a history of mild or infrequent mycotic infections, you don't have to avoid nor discontinue. Certainly, you could just treat with appropriate antifungal medications. While it's rare, there are post-marketing reports of serious complicated UTIs or urosepsis. So again, just really making sure we're screening and avoiding in patients that have a history of severe frequent UTIs. Finally, in terms of dehydration, it's not an official precaution on the label, but it's actually one of the most common reasons for discontinuation of this drug. Patients have been hospitalized for AKI and require IV fluids. And so I always make sure to tell my patients to drink lots of water, emphasizing 6 to 8 glasses a day if that is okay with their other comorbidities. And finally, the endocrinologists that I work with typically do not prescribe this drug class to patients with A1Cs over 10, and that's due to their increased risk of mycotic infections and dehydration. So if you have a patient with very high blood sugars, you may want to consider alternative agents such as sulfonylureas or basal insulin, and then help that patient get closer and below 9%, and then add that SGLT2 on. So now we're going to kind of switch gears to some rare adverse events, but it is important, while they are rare, to discuss with patients so they are aware of how to present and seek help. So first, canagliflozin has been associated with increased risk of fractures. The risk seems to stem from dizziness and more frequent falls. So certainly we want to screen our patients for fall risk and monitor closely those with low blood pressure. Some agents have been associated with increased risk of lower limb amputation. However, it's important to point out that it's lower than initially thought. So the FDA actually removed the black box warning that used to be associated with canagliflozin. I do think it's prudent to consider avoiding this drug class in patients with known peripheral vascular disease and or with a history of amputation. And Dr. Oshman, my co-director, often communicates with patients' vascular surgeons for patients at very high risk. And finally, we want to be sure all patients that receive this drug, regardless of history, are told to closely monitor their feet. There's been 10 cases reported of bladder cancer with dapagliflozin reported in the labeling. However, the majority of these cases were actually reported within a couple of months of patients starting these drugs. And we do not have any long-term data. So a prudent step may be to avoid dapagliflozin specifically in patients with a high risk or have a history of bladder cancer. And then finally, although rare, there are post-marketing reports of necrotizing fasciitis of the perineum. And so we want to be sure to provide our patients with anticipatory guidance and make them aware of symptoms. And so they should be told to seek care if severe, abrupt onset of pain in their genitalia that spreads to the abdominal and gluteal muscles. All right, so wrapping up, a couple things we need to also keep in mind in terms of other medications when we start patients on SGLT2s. And so as we know, SGLT2s can lower blood pressure. So about 4 to 10 millimeters of mercury, given that they behave sort of like osmotic diuretics. And so we want to be sure to maybe consider holding diuretics at first and restarting them at patients at risk for hypotension. These agents can also cause nocturia and urinary frequency. So we want to, again, go back to that assessment of fall risk. And that might be another reason why we want to hold or lower the doses of other medications. And as mentioned, SGLT2s do not independently cause hypoglycemia, but if a patient is on basal insulin or sulfonylureas, depending on the risk of the patient that you feel for hypoglycemia, then we could, of course, either do some dose reduction or in the case of sulfonylureas, hold as we see how patient responds to this new medication. And then finally, it's been mentioned about the risk of AKI. And so just really want to be sure that we're monitoring their kidney function closely, especially in those with declining renal function below 45, and communicate with specialists if needed in terms of altering other medications, loop diuretics and whatnot. And I do want to put a plug in here for making sure to tell patients to be holding SGLT2s if they are sick and unable to eat. We're going to come back to that in a second. So I always like sharing this slide as I feel like I'm a visual person and this stays in my mind. And so this just shows the various the various trials. So Credence, DAPA-CKD, and EMPA-Kidney trials. And you'll see a dip in each and every one, and that's the dip in renal function that we expect with these agents. And so typically, if I have a patient with reduced renal function, I see a lot of patients with GFRs below 60 and 50. So I'm typically ordering a basic in all of my patients afterwards. So about 3 to 4 weeks out, grab a basic. But the bigger thing is, because of these images, hopefully remembering that we do expect that renal function to rebound and improve. And so not having a knee-jerk reaction to that initial dip in their creatinine and GFR. But just like with ACEs and ARBs, if we have a creatinine spike greater than 30%, it may be prudent to discontinue these medications. So monitoring parameters are listed here, and we've discussed many of this already. So now we're going to come back to our patient PV. And so considering all that we've gone through, do you think you'd want to add a new medication? It's a little hard having everybody just names on a screen. So I'm going to pretend that you all said, yeah, let's add an SGLT2. So in this patient, I decided to add Jardiance, 10 milligrams. And so I want you to continue thinking about PV as we go through these remaining slides. So there was an FDA alert issued for the entire drug class regarding euglycemic ketoacidosis in 2015. And so the presenting factors that really stumped a lot of people prior to this alert was that patients were presenting at much lower glucose levels than we typically see with DKA. And they found that the causes for this euglycemic ketoacidosis in patients taking SGLT2s was attributed to either major illness, which resulted in reduced food intake and fluid intake, reduction in insulin doses, and also alcohol abuse. And so why this is so important is we need to be sure to make sure, as mentioned previously, that we talk to patients about sick day management. And so if they're sick and not eating or drinking, they should be told to skip their dose of their SGLT2 that day. And we're going to go through implications in diet and surgery here in a second. So I'm always surprised, the shock that I receive when I'm talking to various individuals in other disciplines when I ask, are you asking patients about their approximate carbs in their diet? And often they look at me with blank faces. And so we want to be sure to ask our patients how many carbs they're eating, if they're eating a keto diet, if they're utilizing intermittent fasting. And the reason is because if they are following a keto strict diet, so less than 50 grams of carbs per day, SGLT2s are actually contraindicated in individuals eating that low amount of carbs. And so I typically review with patients. That's just part of my visit routine, is to go over diet in some amount of detail. And so I typically have a good idea. But in patients that I'm starting an SGLT2, and perhaps we're working on lowering their carbs in their diet, but they're not at the point of keto, they might just be doing low carbs of somewhere around 80 to 100 grams. I just on the safe side, because patients tend to hit the cutoffs that we say. So I typically tell them keep above 60 grams of carbs, even though the cutoff is truly 50. And then finally, just educating patients around this. And so if I have a patient that is truly working on cutting the carbs, this is a question that I ask at each and every visit. So these are the most recent recommendations from the American College of Cardiology, and this stems from that FDA alert back in 2015, and this was updated in 2020. And so the recommendations are now to hold an SGLT2 4 days prior to surgery. And in terms of restarting, we typically tell patients to restart when they're able to eat. However, if there's any nausea present, we want to continue to hold that medication until they're back to their normal eating habits. So while our focus is of course on diabetes care, I always like to point out which of these SGLT2s also have added indications. And so again, I'm a visual learner, so I try to create a chart that maybe you can help you remember. And so dapagliflozin and empagliflozin, as you can see across the board, all have indications in heart failure, CKD, and then of course ASCVD reduction. And so why this is important is this drug class is not only, you know, of interest to us, but our colleagues in cardiology and nephrology. Here's another one of my charts. I tried to, again, create something that you can remember. And so when we're dealing with non-diabetes education and trying to think of renal cutoffs, it's mapped out here. And so the one thing that's nice, I will point out, is between these two agents, which have different starting doses, 10 milligrams is across the board the dose when used for either heart failure or CKD, and that is with dapagliflozin or empagliflozin. And as you can see here too, the renal cutoffs, as I mentioned, are lower than what we see for that glycemic impact. And so again, often a point of confusion. And so I hope that this graphic can help you remember. So just as Jonathan commented, we have a dosing escalation guide with all of these tips and whatnot and the non-diabetes indications on our website. And currently these are under review and update. So a new one should be coming out here in the next few weeks. I didn't spend much time earlier when I mentioned at the very beginning, you know, when you think about cardio risk reduction, we think of ASCVD, heart failure, and CKD. But there's also the point about patients with multiple high risk factors. And so the high risk factors are listed here. And so it's important to note, though, while there is a recommendation for consideration of use of GLPs and SGLT2s in patients with multiple high-risk factors, the ADA gave this a weaker recommendation for this particular population, given the cardiovascular outcome trials were not powered for primary analysis in this subgroup. Furthermore, there was just a publication, a cost-effectiveness study, and it demonstrated a marginal difference in benefit when they looked at first-line metformin versus first-line GLP versus first-line SGLT2. And so if cost was equal, this would be a no-brainer. But unfortunately, we are in the landscape that we are. And so it's going to be interesting to see in the future how the landscape changes with hopeful generics coming out and then Medicare's ability to negotiate prices here in 2026. So in summary, I put together this chart in hopes of wrapping everything up just to give you another visual as we, always consider glycemic lowering on that first column, but then also trying to think of the other benefits of drugs. And so as you see, the highlighted GLPs and SGLT2s across the board are going to offer robust A1C lowering, some, as mentioned earlier, provide cardiovascular risk reduction, as well as some with heart failure and CKD, and then again, positive effects in weight loss. So here's another resource that we have on our website, and so the QR code is here. And so I created this too. It's based off the ADA guidelines, but what I wanted was a one-pager in terms of what medications to consider, which are the ones that specifically have that proven benefit. So if you are familiar with the ADA guidelines, there's lots of footnotes and you have to go read the fine print. So hopefully you'll find this useful. On the flip side, there's lots of recommendations for medication management with other meds in terms of reduced doses and surgery recommendations. All right, so back to our PV. So just to kind of give an idea, 3 months follow-up after we started the Jardiance, A1C is down to 7.6. He's tolerating it just fine. He's enrolled in cardiovascular rehab. His blood pressure today is looking great at 116/72. He's actually lost 8 pounds. And so while this has all happened in the last 3 months, he was also seeing the PharmD, and de-escalation of insulin had been occurring too. So that could contribute to that weight loss. So what's your next step? So things to consider is thinking about tolerance. We want to make sure he is tolerating it. BMP was unremarkable. His blood pressure is good control. So I think it's very reasonable to increase that empagliflozin. At the same time, I would likely decrease or discontinue that insulin and see how blood sugars respond. Keep it in my back pocket that if I need further glycemic impact, if you recall, he was also on max dose dulaglutide. And so as Jonathan reviewed, certainly we could consider a more potent GLP or GIP in this patient to help with that increased glucose if needed. All right, so with that, I'm going to switch it back over to Jonathan. We're going to talk about some challenges in prescribing these agents.
So we've explained the benefits, the contraindications, the risks, and prescribing practices to these medications. But as a lot of you may already know, there are challenges to getting these medications into the hands of our patients. These are some of the common challenges to prescribing. So number one, when you add a new medication, especially the incretin hormones, what do we do with the old medications? So our general approach is to initially base it on what their current A1C is. So if their A1C is greater than 8%, we do not reduce the dose of insulin. If it's less than 8%, we should consider a reduction of 20% of basal insulin initially. For prandial insulin, if on a lower dose, we can consider discontinuation. And for higher doses, they may benefit from a 50% reduction. For sulfonylureas, I typically recommend stopping the medication altogether. And then for the other ones like metformin, or if they're on an SGLT2 and we're starting an incretin, or if they're on an incretin and starting an SGLT2, we can use them synergistically. When is it appropriate to start insulin? So I think it's important to note, right, because we keep recommending taking it off, right? But we can immediately start insulin if they're experiencing symptoms of severe hypoglycemia or hyperglycemia, if we suspect type 1 diabetes, or they're experiencing an acute glycemic dysregulation. In a person that has had challenges controlling their blood sugar, we can consider adding insulin if they're already on these medications and they're not on at their A1C goal. In regards to explaining these benefits, all these benefits that we discussed to our patients, the collaborative Michigan MCT2D has patient-friendly resources on their website to explain many of the expectations we discussed here today. So who here has experienced medication shortages? I think this might be the biggest challenge we have all faced over the last year plus. And although it is getting better from my experience over the last few months, we should still anticipate some of these issues. We've developed this tool that we've updated very recently to help during these shortages. So what do we do if we need to switch between incretin hormones? What about if there's a gap in therapy? So the top table shows equivalent doses. The priming dose, that initial dose, is removed for each one because they already have it in their system. What happens if the patient misses doses? So they miss a dose for one to 2 doses or 3 to 4 doses. On the bottom here, you'll see what to do with semaglutide and tirzepatide if they miss those doses. Switching back to you, Heidi.
Yep, I think we're getting good at switching quick here. All right, so are these medications covered? And so I think thankfully we've seen this become an easier challenge than when these agents first came out. And so MCT2D has lots of resources to help you and your practices out. So this is available on our website. And so as you can see, there's a lot of green, meaning there is a lot of coverage across all the various, this happens to be Medicare Advantage, and then, I don't know what happened. I used to have a commercial one pop up too. But in general, both are well covered. Sometimes step therapy is required. You'll see ICD-910 in the prescription noted often in this chart. I've gotten into the habit in every prescription that I write for GLP, including that diagnosis code, because some of the plans have a type of prior authorization that the pharmacy can automatically override if they do have that indication on the prescription. So just a little tip there for you. And then as you can see, a tiny little Michigan Medicaid, Byetta, Trulicity, and Victoza are the preferred incretins for Michigan Medicaid. For SGLT2s, it's really a shift. And so it might not be surprising after the charts that we went through and the various indications outside of just diabetes, along with some of the side effects, that you see broad coverage of Jardiance, and then nearly right there beside it is Farxiga, dapagliflozin. For Michigan Medicaid, they cover the big three, as I refer to them, so Farxiga, Invokana, and Jardiance. So coming soon, I hope in the next few months, in addition to the chart that I shared, we're going to have a interactive coverage checker. And so I don't know if you've had the opportunity yet to check out the coverage checker in terms of CGMs, but I would encourage you to do so. It's pretty cool. You pick the plan. We only have a handful of plans, so certainly this is something that's going to evolve over the upcoming years. But it gives you very detailed information, including statements that you can easily copy and make into a dot phrase for your own EMR. And this just gives you an idea. This, again, is the CGM screenshot, but as you can see, you would pick your plan, and then from there it tells you if it's covered. It would even tell you, in the case of CGMs, if it's covered at a DME or pharmacy. All right, so the next few tools, just in the last few minutes, I'm going to go over. I really want to make sure we think about how much diabetes care as a team. We got to work as a team to treat this disease. And so please share these tools across your team. So we have resources here to help with not only coverage, but in some patients, specifically Medicare Part D patients, they actually can qualify for some of these patient assistance programs. So not only do we have copay savings card summaries here, which are only for commercial, but the more important one, in my opinion, in terms of the patients that I see, are those patient assistance programs, and many Part D patients are eligible for these if they meet the income requirements, which are stated on our tools. Next is empowering our patients. And so when all else fails, if none of our tools allow you to figure out what is covered, especially in the case of CGMs, this is another tool we created to try to help you provide something to your patients so they can call their insurance, get the information that you need to make a decision, and then get this back to you. And then I chuckle at this one, but I when talking to my clinical team, remind that if we can't find formulary information on any of the tools, when all else fails, you can always just throw the name of the plan and the year into Google, and you'll often find a PDF that offers the formulary. So just a quick tip there. I quickly mentioned earlier about Medicare being negotiating prices. And so just as a reminder, this is the 10 medications that have been picked for 2026. They have not released what these drugs will cost our Medicare patients, but just so you're aware, that is coming. So to give you an idea of what we've been doing since we started in fall of 2021, just wanted to show the success that we've had with improving prescribing rates of SGLT2s and GLPs, not only in primary care, but also across endocrinology. We're going to talk more about this, and you're going to hear more about this, but just to keep in mind the use of our dashboard to try to target your patients that might benefit from these medications that we've discussed today. And with that, we're right on time, but I'm happy to stay and answer any questions that might be out there. And I thank you so much for attending. All right. Well, I see a lot of people dropping off. So thank you again. I hope you all have a wonderful day. Bye-bye.